trouble, eh?
Is it county minute?
Is he here? Please, he's here. He's the one now.
This is the Kitui County.
Kitui County, water.
Not national.
Not national. Yeah. That is fine. Because you're now going to represent all the water people in the government. Eh? Yeah. So, in your perspective, how is, first of all, right now, how is the WASH coordinated in your environment, in your county? And how can this be improved, this multi-sectoral collaboration? Over to you.
Yeah, thank you, and good morning. Yeah, I'm Kennedy Mutati, the County Director, Water Services, Kitui County. Yeah, it's a pleasure to be here to have a conversation on integration of these WASH engagements, and particularly how WASH is relevant to the elimination of these NTDs. Maybe to give a case of Kitui County, we have a WASH forum. That's a forum that basically brings on board partners in WASH. That's the development partners at NGOs, the county departments in water, health, education, and also the national entities within the county. That's the National Department of Education. We also have other partners, specifically UNICEF, and we've also at times been having other national, maybe level partners that come on board to backstop us. This was established way back in 2014. But it wasn't inked on any government legislation or government framework, but we have since, through the support from World Bank, we have a program which is called KWASH. That's a Kenya Water and Sanitation Hygiene Program that targets to achieve universal coverage, or at least ensuring access to the residents to a distance of 1 kilometer by 2030. We have already developed a plan, and we have worked on SWIP. SWIP is a county water sanitation, county water strategy and sanitation and investment plan. And on matters coordination, we have really outlined on how each sector is going to be brought on board, because emphasis is put much on HCFs, healthcare facilities, and public institutions like primary schools and secondary schools. So basically we bring on board all those actors in WASH, whereby we have water department and health as the people in the secretariat. Thank you.
Thank you very much for that elaborate explanation. I saw one of the panelists smiling because she had been joined by a fellow lady. Eh? I don't know if it's a gender issue or we should get the ladies to go sit there. But that's okay, that's okay. Now let's go to the educationist. What is the current situation and role played by the education department, and how can it be enhanced in this collaboration, in your view?
Thank you very much. My name is Nicholas Campbell. I'm the Director of Education and Baringo. Now, in relation to the question that we have been asked, I want to talk about how education county is this type of collaboration. Education is the agent of social change. Education is essentially where you can easily give out information, and that information becomes a lifelong stage in the society. Now, in education, we normally have, I would say, we have issues that is what we intend to do, that is called the mandate of education. But we also have other things that you acquire within education, that is a lasting function of education. Those things that you acquire, not by people, actually by people, not by people. So, something like hand washing, something like
Give you a question immediately.
Thank you. I wish you don't just ask immediately. I'm still breathing after climbing the stairs very fast. So I am Paul Lotu, the county director in charge of water, Turkana County.
Thank you. You were the one we were waiting for to give us some metrics on the current wash situation. But before we go there, I know there is a role, a convening role that is being played with the support of some partners. Now I am getting to site savers. What role do you believe that the partners can play in driving this integration of WASH into F&E? What is the current situation and how can we improve it from a partner perspective? Thank you. Okay.
Okay, thank you very much, moderator. I think I want to give the perspective of partner support, the perspective of site savers, and what we did as Site Savers Uganda country office. When we started this, the journey towards the Trachoma, the national Trachoma elimination program, we started with a very robust program which was encompassing the whole safe strategy. And so there was the component of facial cleanliness and environmental improvement, which I want to say that it's a very heavy, hectic component, but very important because it is what sustains the S and A aspect component of the safe strategy. And so when we started, we had quite a number of partners specifically for F&E that collaborated, worked closely with the government, and that was specifically the Ministry of Water, Environment and Sanitation in order to speed up the F&E component. And there were specific indicators around how to improve the facial cleanness, the environmental practices in the communities. And the communities that were targeting at that point were really very needy communities where, facial cleanness needed so much attention, environmental improvement needed so much attention. So the focus was how do we increase access to, for example, water services, how do we increase coverage of pit latrines. And so that, I think, ran for a period of 3 or 4 to 5 years. But as I said, F&E is a very demanding component. It's very expensive to deliver F&E projects. And so the collaboration, the involvement, having the ministry be the lead partner responsible for this is very, very important, because as partners, you really don't have, what you get is a project of 1, 2, 3 years and it comes to an end. But the most important thing is that how do you continue, how do you sustain the gains? So I think the role that we played was to make sure that the Ministry of Education, they're on board with us, they've taken lead of this program, because government programs around F&E do not wither. Whether there is fund, government will always be there. And so our support was for that period of time, and we made sure that there was strong involvement, engagement, and leadership from the Ministry of Water as the mother ministry for this.
So let's look at
for this component. And so as we transition from the active program delivery, making sure we build those indicators, we increase those indicators. We're looking at how we sustain this going forward.
You may find it difficult to track your
Ministry
payouts,
of Water taking
reconcile your
leadership
transactions, and so on and so on,
around that
which
area
leads us
was
to
very,
open
very
front.
important.
The number number one,
as
money
we
management
transition right
solution
now,
for
the
your money out
involvement, the
situation.
leadership
So
from
here's
that,
5 reasons why
ministry
you need
has continued to
Number one, easy
they've continued to take
reconciliation.
up their
Keeping track of where your
leadership.
money
One
goes
thing we
is
supported them
vital.
was to make sure
Open
that
Float
they're
allows you
actually
to track
involved, even
who
up
you
to now
paid
when we're,
and why
for
you
example,
paid them.
doing
With
program
receipts
review
and
meetings for the
invoices
National
needed before
Trachoma
payment
program.
can be
We
done.
have a
Number two,
specific
flat rate
involvement
fees
of
with no
Ministry of
limit.
Water,
Send any
and they
amount
have
to
the
any bank
responsibility
or
to
M-Pesa
come
at
and
a
give
flat rate
accountability
fee,
to the
no hidden
program and say,
charges.
look, this is
3,
where we are
fund
in terms
security.
of our
Open Float
indicators,
has a meter
and
checker
these are the
system,
challenges
which
that
allows
we
you to
face,
have
and these are the
multiple
plans that
users
we have
with
going
different
forward.
rights.
And we think
For
that that is
example,
how
you can have
this
one user
component
with rights
will
to
be
initiate a
sustained even
payment,
beyond
while another
elimination
user has the
time frame.
exclusive
Yeah.
rights
So I
to
think I can
approve
end
that
there for now.
payment.
Thank you very
4,
much.
make
Thank you.
payments
That
any day,
brilliant lady
anytime,
is from Teso.
anywhere. As opposed to other payment
I think
systems
Teso,
where payments
they
are
always
only
confuse us
processed
whether they are
at
from
specific
Kenya or
times.
Uganda
With Open
or
Float,
both.
you can make a payment
So now
at midnight
she gave the
and
Uganda
they will receive
perspective.
it instantly.
So my
And
brother will
finally,
give us
Hakikisha, which lets
a
you confirm
response
the name of the
from the side of
beneficiary
the border.
before the payout is done. So no errors or money loss. Head over to openfloat.africa to find out more on what Open Float can do for your business.
By partners like Cytel and Fredolus, Christians and Insurance, Operation Hindsight Universal, who are mostly focused on health and really looking at any preventable plans. Is really an advocacy role, trying to highlight issues on how the support from other players who are really investing in wash is actually helping achieve.
My name is Emmanuel Ryan Bugwa, country manager of Venice, Kenya, a fintech financial company that is supporting agri-SMEs by offering tailor-made financial solutions to help them grow their business and also meet their business operational needs. So here today we were doing the Avenues KE launch. Not to say that Avenues Kenya is a new company. We've been in the market for the last 3 years, interacting and potentially financing and supporting agri-SMEs. So we've done quite a lot of forums, a lot of workshops, and we financed quite a number of businesses. Our financing solution, we have 3 main products. That is, one is the agri credit line. This is a product that is tailor-made to fit the retail businesses, the small businesses that are supporting the agriculture sector. So what we do, we go and interact with the businesses, we assess their needs, we assess their operations, and we empower them.
Definitely the equipments are provided for TT surgeries in the next 2 to 3 years. Domestic resource mobilization, we, together with partners, we developed a tool for enhancing resource mobilization and allocation at sub-national level. This was in 2023, and I can say that our districts, we have the districts I showed you in the, on the map, about 5 districts that were requested of assistant active trachoma, and these districts have gone ahead to allocate monies, whether it's for supervision, whether, and we hope that this will actually be in a more incremental fashion over the years. But also at the national level, we the recent budget review, I think last month, we still fell under the unfunded priorities NTD intervention. So we still continue to request for more money, and so far the indications they may get us, just the bare minimum. So we, as Uganda, having this at both the national and
specifically that investments go to areas where we have it. So at the end of the day, our advocacy is here to make sure that wash investments, irrespective of who is investing, then go to areas where we have interest in energy.
Oh, we've heard from, Sarah wants to add?
Yes, I think I want to, I missed out the component of social behavior change. That is also one of the areas that was given a very strong support by the partners and to the government, and this involved development of a social behavior change strategy, so that issues. In Uganda, I don't know whether this also happens in Kenya. There's so many other myths around, for example, use of pit latrines. Like we have communities that, for example, if I'm a lady and I am pregnant, I am not supposed to use a pit latrine. Okay, that's just one example. So there were a lot of interventions around development of communication materials, but also sensitization around targeting school children in schools, because we generally believe that the children are the agents of change. The young people are the agents of change, because they still also have more years ahead, and then they can speak to their parents. They can carry this information to their families, to their mothers, so there are a lot of interventions around schools targeting children, and then behavior change and communication materials, IIC materials, and then we also had jingles support around all that to improve information that goes out, access to information around the bad and good behavior practices around WASH and social behavior change. Yeah, so that's what I wanted to add. Thank you.
Thank you very much, Sarah. I am aware there's a lot of that advocacy done during the period of the Queen Elizabeth Diamond Jubilee Trust, a lot of baseline and endline studies related to F&E. So thank you for carrying over those learnings. We've heard from the partners and from education and from government, but the gentleman from water just came in, and I promised to ask him a question immediately. So from the water perspective, how do you see this coordination working in practice, and which policies do you have that are enabling this collaboration, and probably which challenges are you facing? So you could give him the mic.
Thank you very much. Before I respond to the questions you just raised, I want to clearly spell out that the role of any county department or Ministry of Water is to ensure that the water supply infrastructure is in place and is serving the purpose. So, having said that, the same department may be involved again in actually making sure that this water supply is sustainable and reliable to serve all the functions that it might have been set for. Now, looking at the WASH perspective, I think I want to say the collaboration comes in when we have various state departments, various county departments, non-state actors, all working towards one common goal: improvement of WASH services that actually get into now handling the last part of the SAFE strategy, that is the facial and environmental improvement. So when water is available and be in good quality, and of course in adequate quantities, as actually provided by the the Constitution of Kenya, Article 43, we are able to solve the so-called WASH-related illnesses. One of those now wash-related illnesses is trachoma, because in the absence of water, then we are not speaking wash. We cannot wash our faces. Unless otherwise there is someone in this room who tells me, if he wakes up in the morning, he will use his saliva to wipe his eyes and feel safe. If such a kind of person is here, then I would say he's in the wrong place. Because we require water that is safe and adequate to perform the function of, the facial cleanness, actually. Because the thing is, you could be getting water that is contaminated. Again, you get into your face. I would doubt you will be contaminating your eyes more, and maybe your situation may be worse. So that's just my thinking. And in the natural context, I've always looked at water as both curative and preventive medicine. And if you doubt, those of you who read the Bible, you must have heard of a man who could not reach the pool when it was stirred by the angel. So this man wanted to get there. And the solution was, he was to get to the pool. And what was in the pool was? Hello? Hello? What was in the pool? Yes, again, to get you a bit of wayward. But I hope you don't get offside. If you read Genesis chapter 1, verse 2, water is mentioned. And the second thing that is mentioned is the presence of God. Are you getting? The creator of the universe is with water. And the priority for any existence or any life on the face of this continent is, thank you. Now, getting back to my coordination, the coordination practices and how we work with WASH partners. One, I want to say, as a county department of water, or Turkana County government, we have our Turkana County Water Act 2019. This act establishes the County WASH Forum. It is here we discuss WASH-related issues. So it is this platform that we can actually have all our partners, all our related kind of departments. For example, the Ministry of Health. The only department that I miss in that forum, to be sincere, is the Department of Education. But all the same, it is the act that guides who becomes a member of that forum. Again, in this kind of forum, it is where now we discuss, just as my brother had said, we discuss WASH interventions and where they will be needed. So we may have maybe a partner like maybe Fred Holos. They may say we want to improve maybe WASH in schools. We may want to improve WASH in health centers. So from there we can say Fred Holos is doing this and this intervention in a particular place. So in the coordination spheres, we need to know which partner is where and doing what in relation to the WASH interventions. Still on policies, I would also want to inform this sitting that we have the Turkana County Water Policy. And one good thing it spells out clearly is water and sanitation issues are streamlined into this policy. So we are talking of WASH in schools and WASH in the health facilities. So the big thing there will be collaboration between the two departments so that we know which health facility requires water and which school also exists in the absence of water, which is a big challenge. Maybe in the past we must have we have experienced having facilities without water. And for a case of a health facility, that's a bad case because several things need to work or move without water. That is, we can't actually do some of the things in the hospital again without water. The sanitation aspect, the hygiene aspect, and all that. Sorry, it looks like I'm taking a lot of time, but again, on the challenges, I'm not saying we're having any challenge on coordination issues. The big challenge is the budget to develop, implement, and operationalize wash interventions. For our case, we have one of the largest counties in this nation, and it runs all the way from Lokchoge to Kapedo. That kind of expanse may require targeted kind of intervention. You cannot say, I'm putting all, maybe, water supplies in all the villages at once. Otherwise, having taken a lot of time, thank you very much, and I will be available for any easy and difficult questions.
Thank you, thank you. I'll now go to the lady in red. I'm aware you've done some studies in this area. From these studies, and I know you're still doing some analysis, and considering the audience we have here, the varied audience, Uganda, Kenya, academia, the various counties, what stands out in terms of practical interventions or practical approaches to integrate F&E into current approaches like CLTS or school wash or some other hygiene campaign? What stands out? What message do you have for us? Like if you're telling me that from your study, you should do A, B, C, what stands out, prominently? Thank you.
Thank you for that question. From the studies that we've done one on F&E. It was a study and an implementation at the same time, piloted in West Pokot County. And I think basing on the WHO WASH NTD strategy, it mentioned that most of our NTDs are hygiene, water, sanitation, and hygiene based. That is where we have a problem. And as we move into the transition plans, from what we found out from the findings, is that F&E, integrating WASH into F&E basically lies in a social behavior change communication at the community level. So we need to involve our community people, especially using models like community action model, so that we can change attitudes, norms, and practices at the lower level. And through use of IEC materials at the community level, we can be able to ensure that our communities actually accept F&E. It is actually one thing to provide water and adequate water, and it's another thing for the community to actually use this water. Let's take a case of when we had COVID-19. There was water everywhere, and people were washing hands. But at some point, it was the children. Towards the end, it was the children who were washing hands more and not as adults. So it is just attitudes and behavior change at the community level. So we can leverage on models like the community action model, where we identify the needs at the community level. Then based on these needs, we come up with interventions that actually fit and suit the communities. Thank you.
Very challenging. Especially when you say who was washing hands. I could even say who was washing faces. Maybe, we are a very distinguished panel here. We are the leaders, we are at the top. But, like, how many times do you wash a face? Those who wash once a day? Is it only me? Twice a day? Twice a day, at least, yeah. 3 times a day? Can you imagine you're doing well because you're above 50%, because the twice a day were the most hands. Those of us who are very honest and said once a day, we were very few. I think most of the time people will tell you, I only wash my face when I'm bathing, not so. So if you take a shower in the morning, face is included. It's not intentional, it is a side meeting, not so. It's not intentional. Others, Stephen is saying it twice, 3 times. What? More than twice. The WASH people tell us 3 times. I fear to answer how many times do you bathe in a day, based on a boarding school experience. Professor.
I'm sorry I have stood to protest, because what is meant by wash? Wash is meant to keep the face clean. Whom did we say has got the highest risk of active trachoma and transmission? It is children. There are mothers here. How often should you wash a child? Huh? It is not 2, it's not 3, it's as long as it takes to keep the face clean. I think that is the message we should pass. These numbers don't work. We know a child, if they are held by somebody they don't like, they will cry. What happens once they cry? There is mucus on the nose and everything. You may have washed that child 2 minutes ago, but we require wash that has an impact on the face. The issue is not the process. The issue is to keep the face clean. If your face, you wash it once in a day, and it is clean the whole day, there is no problem. But a child is crying, the child is feeding, and they have got food particles on the eye, which attracts flies. So we need wash which is effective to keep the face clean. And that is why I have said I'm standing to protest those numbers. Don't keep those numbers. Train the mothers to check the child and keep the face clean. We need a clean face. We don't want the rigor. It's not an issue of how many times. It is an issue of keeping the face clean. That is why we do not call it face washing. You are looking for indicators for face washing. What we want is an indicator for clean. My protest has ended.
Thank you. Well taken. I have a disclaimer. When you say protest, it depends if you are in Uganda or you're in Kenya. In Uganda, you might not manage to protest, but well done. Now, this takes me to my final panelist. My brother, I have been informed that you can answer this question best. You've had all the players, and now in your situation, how can we make sure these players work together best in your situation? Thank you.
The office that is coordinating is domiciled in. It should be well stated such that the buck stops somewhere. It will be very easy when if it's the director of water calling for a meeting to coordinate a wash, like in Westcott, it should fall only on him, as opposed to like what has been happening. So we really need all these players to be brought together, even if it's planning, implementation. So I think basically even the other thing is policy. We really need these things to be embedded in the policy. Yeah. So the policy, even it comes from the national and it's domesticated in our counties. Once it's in our policy, I think that will come out very clearly. Otherwise, I think that will work out.
Thank you very much. Because this Minister of Health, Uganda, and of Kenya. Thank you very much. You have already given them half the answers, I think even more than that. But again, as a ministry, it falls on you. A lot of responsibility in this case falls on you. But before we hear from them, any questions for my panelists? As you can see, it's an international panel. International, it's international, inter-county, international, interdisciplinary, everything. So they can answer any question. Minister of Health, Uganda wants to ask.
Yes, thank you so much. I just before Professor gave his input, I was remembering, I don't know if this is the situation actually in most of our communities. When I was young and starting primary one, that's how we call it in Uganda, most of us as children did not have the opportunity to bathe in the morning. Reason being, you had to take goats, and tether them. You have to sweep the compound, and school starts at 8. So what was important is before, you just go and probably wash a little bit of your legs, a little bit of your arms. If you're lucky, you wash a little bit of the face. Before you know, you're picking your backpack to run to school. Okay? And so with all that, with what Professor said, so what are really these, especially when we are talking of whether it's school, what do we look out for? Do we look for moments of face washing? What are the indicators, especially the M&E part, for this facial cleanness, whether in the community setting or in the school setting? Because I'm assuming some of the rural communities that are working, I am almost sure those children don't bathe in the morning before going to school, but they bathe in the evening when they come back. Sometimes it's because of the house calls, the ladies, the young girls sometimes have to help a little bit before going to school. So that's my first question. So what are those indicators? Whether you're talking about face washing or you're talking about facial cleanness, as Professor said. Then I think, again, to I don't know which of the panelists, in most of our communities, the issue of the scent from the latrines in some of our communities, really, even when, try to do the software, the SBCC, the issue of the, sometimes the stench which comes from the latrines, puts most of our community members away, and issues of, the loose soils. And I want to hear if there's an experience in whether in one of the counties, how they are dealing with that. Thank you.
Thank you, Dr. Pon. 2 questions. One needs a wash expert or volunteer. The other one needs education. Yes. They are noting them down. Any other questions? We want to take them once and then we have a reply and move on to the next panel.
Thank you so much. And my question is on social behavior change, communication. And from what I've learned from my sister from Uganda, maybe she was asking whether we are doing it in Kenya, but okay, we are doing it. But what I want to understand is, when we are doing social behavior change communication, what message are we giving the person? How are we unpackaging this message? Because I've been always seeing people talking about it, but it does not make a lot of impact. You come up with very good posters, you come up with very good murals, But at the end of the day, we have not solved any problem. So we need to come out clearly on how do we take this message, who should be passing this message. Because like myself, I'm a health worker. I know all these messages, and then I go to a public baraza, what we call baraza in Kenya, or public gathering. I send the message there, but who follows up? That is now where we miss the point, because we have very good messages, very good strategies, but there's no impact. Thank you.
Thank you very much for the panelists. Mine are two issues. One, we appreciate the role of multi-sectoral collaboration in issues of WASH. So in that context, Ministry of Education, you know, when I was growing up, our teachers were inspectors. They would inspect the children in issues to do with hygiene. But over time, I think the inspection has gone down. But we have a chance or an opportunity to empower our teachers with that message of hygiene. Number two, when a presenter was presenting yesterday, he showed us a slide on health assistant. I think he was doing like some health education to school children. I think it's from Uganda. So this human resource, the health inspector, is it a community? Is he a community-based worker, or is a professional? At what level? And what are the structures like for this kind of worker? Thank you very much.
Maybe, I offer to respond to the question about the smell from the latrines. And let me say that yesterday during the presentation, I saw a photo of a latrine whereby the vent pipe, actually that vent pipe is not functional. For air to flow out, it has to be stood, but you see it in bend. You remember that the structure. So actually that is just a decorated pit latrine. The vent pipe is not functional completely. So for us, what we are doing, I would cite for like Kitui County, what we are doing installation of sanitation products we call SATO, which have we improve the existing latrine. That pit latrine that has been smelling, we retrofit what we call, we have products called SATO pans, and it has a cover which overlaps. When you are using it, it opens, but when you are not using it, it is always closed. So there's no smell that is coming out of that the toilet. There are no flies. You may not even know whether it is a latrine, because there will be no smell. And I know most of the counties in Kenya are also doing the same. When you're doing this market-based sanitation, that is what we are embracing. And for the vent pipes, we are advocating that the vent pipe be in the outer side of the wall, so that the principles of the use of vent pipe are well applied. Otherwise, if it is bent like this, it is just a decoration. Thank you.
Thank you. Well, that photo has caused problems. Yes, Akor.
Okay. Thank you so much, moderator and the panel. For me, I just wanted to weigh in on two things. One, I know that the education department is playing a very key role when I listen to the panelists. And personally, I know that the children believe in teachers, and what the teachers tell them is difficult to unlock it from the children. But we also need to agree or to believe to understand that at home the children listen to their parents and parents make decisions on children. I have witnessed situations where the child is asked, why are you washing your hands? Why are you wasting water? All the time you're washing your hands. Can you leave that water? Because parents are buying water. If they're not buying, maybe they're getting from a little far place, so they are mean with their water. They want children to use it maybe for... So you find that much as the teachers tell children to use the water to wash themselves, to clean, at home, they have got to ask and provide explanation why they must use the water in some homes. So my thinking is that perhaps maybe when it comes to policy issues, because there are activities that bring parents to school. So can the schools, through maybe some policy changes, ensure that during these PTA meetings, the events that bring parents to school, target parents with the messages and make it very clear to parents that these are the diseases that use of water can prevent. We have this in our community. Please ensure that, so that the parents know why children must wash, because they ask the question, why are you washing? So that we have the decision makers back home knowing the relevance why the children should wash. And then the other thing that I wanted to say is on the mobile communities, the pastoralists, and most of the shepherds are young people. Now, people say that the pastoralists don't use water. Their work is just wake up, run with cows. But I've also seen that in Karamoja, where I live, those people can bathe. And it's not just joking bathing. They really do thorough cleaning when they choose to clean. They will clean properly, and you use whatever gadget is around there to clean themselves. Now the issue is access to the what? To water. Because sometimes you can see them cleaning using very dirty water, but they will get out of that dirty water when they are clean. That means they have really put a lot of effort to clean themselves. So, because if someone can use the dirty water to clean and come out when they are looking clean, that's not is a skill to clean. They take time. Now, what do we do as governments? Because we know our problems. We know that there are times when this way is dry, the other side is green, and people go there. There are times when this way is green, the other side is also green, so these people are there now. And providing water, running water for them, because the issue is access. They don't have access. Can we explore issues of policies to ensure that water crosses? Water is available for them from both sides, and because I know boreholes, because of terrain, it is a challenge to governments. But running water, everybody would have this water. When we deliberately, like the way we deliberately during COVID, which was threatening everybody, there were deliberate efforts. Now we are moving towards elimination. We are eliminating trachoma. We don't want it to come back. Why can't we go for deliberate actions also and say, okay, so to sustain the gains, we need to target what, as someone said, target interventions. Provide this water to decide, and also with a mind that, when it's this way, they will cross the other side. Where are they going to be? Let's have running water around there. As they look after the animals, they can use that water to bathe. Because boreholes break down and requires a committee to bring it back. These people have no time to have a committee. They are looking after the animals to collect money to repair a borehole. No. But if the water is there, is running, it's easier. Thank you.
Thank you, James. To wrap this up, I know the next chair might say this man is bringing some Ugandan habits to moderation. To avoid that, we will allow the panelists to respond, and then we'll conclude the early morning panel. So I know there's about 3 of you with questions, but if your colleagues would like to chip in, they can go ahead. You already have the microphone, so why don't you start?
Maybe I can start on SBCC, and the question was asked on what messaging can be done, the targeted people, the packaging of the message. I can give a response briefly, and my colleague here will also give the response from Uganda. So SBC, social behavior change communication is not instant. And it takes some time, it takes a while before you can actually see the behavior change at the community level. So the messaging, especially for trachoma, would be on what we had here. What the causes, the signs and symptoms, what it is, and the prevention measures at the community level. And the target should be both community and I can say children, school-going children as change agents. At community level, we can have community engagement forums like what we used in West Pokot, and you call the community together, you have a discussion, you identify their need, you talk to them about, you give them this information about the disease, and they're able to appreciate that, and they tell you their myths and misconceptions, and you can be able to demystify that through targeted community engagement forums, and also through the use of community opinion leaders, so that this messaging is also done at all levels, at barazas, in the churches. And what we have seen, we have done something on continuous messaging for SBCC on STH schisto, that is schistosomiasis and soil transmitted helminths in the western region. So messaging does not stop, it is continuous, and change will come over time. So it is not an instant, you will not see instantly that behavior has changed, but it will take time. But with continuous messaging, I think we can achieve more with SBCC. And also maybe a comment on the use of posters, the IEC materials. They work, yes, especially when they are tailored for the community, but they're not very, they're not the best. They work only during campaigns. Yeah, so that is also something I can point out. The PA systems, the media, they are short term, but continuous messaging would work very well. And someone mentioned an issue of training our children at the school. I think our children listen so much to their teachers, and what their teachers tell them, they grasp that, and they even come home to tell us parents. My concern would only be for some of our communities who actually, the children don't go to school. So where do they get this messaging? I think that is something we can brainstorm on, because I've worked in a community where there is no school, so these children do not go to school at all. And washing their faces is actually not a priority. Even the parents, water, for them, water has there's a different priority in terms of use for water. So they do not prioritize water, face washing, hand washing. It is not a priority. And they do not even see the need to even wash the face, because they do not know. So unless we go to the communities and we educate them on the importance, they need to see the need of washing their faces so that they can relate. Yeah, thank you.
Thank you very much. I think to pick up from that, I just want to say that SBCC is very complicated, and so even developing strategies or messages that you want to pass for that specific problem, it needs to start from the initial stages. And so if you're looking out for who are the people you're targeting, you need to sit and say, okay, we have a problem, so who are the stakeholders? Because it involves very many stakeholders. You might think that the children are the most affected, but what about the mothers who stay with those children? What about the community, okay? So first of all, important to begin from there. What is the problem assessment, and then who do we want to target in this case? Who are our target? For me, I would say that for certain problems like this one, we need the whole community, because when it comes to even access to water, it is not just a woman, it's not just a child, it's the whole community. When a borehole breaks down, you need the support of the whole community. And then when you talk about which kind of messages, again, the initial processes that you do in co-creating these SBCC messages will give you what kind of message, because the message you portray, that poster you display, that message you talk through during the radio talk show, whatever it is very important. Another person will perceive it in a very different way and can either build, improve what you want, or break, actually destroy what the message you want to communicate out there. So the involvement of the key stakeholders, even in developing these messages for SPC, it is very, very important. But also the other thing, apart from the IC material, is the channel that we use to deliver these messages to the community is very important. You can't assume that what works in community A, in country A, works in the other. It's very important again, and all this you will find in this process that I say that it needs to be an engaging process involving different stakeholders and making sure that whatever goes out there, how you do it, where you do it, matters, because it can either give you positive results or break it. So it's an engaging process. I think I could end there. Thank you.
Okay, just one. I don't know whether I got Dr. Opon's question. You talked something about the facial cleanliness. Yes, which I don't know, but I think you wanted an indicator, which I think Prof mentioned very well. We go with like the percentage of children with clean faces. If you go to a school, you just go but you have your working definition of a clean face. What is it that you look for in a child? Again, it's usually very important because most of our programs have really been concentrating on hand washing. But here we really want to integrate hand washing and face washing. So we can even look at the number or percentage of households with face washing and washing facilities in a household. Are they really there? And these are the issues that we really need to fight for to be embedded in our policies, especially in the semi-arid and arid regions, so that these kind of practices can be adopted at a very early age with our children. Thank you.
Now, thank you very much. I want to respond from the perspective of education. First of all,
A quick one. So, I realize that most of our rural areas are the ones that are culprits of these maybe diseases because of low levels of sanitation coverage or even water access. So, working jointly with the Ministry of Health and Sanitation is that as a Department of Water, we normally have these billboards or signages where we are able to put like some message. So working closely, we'll be able, like if we get a standard kind of communication, we'll be able, because we have been traditionally using like avoid HIV, AIDS kills, but now I think that's already got into people's minds. So we can consider now that other aspect of the washing of face. So we can work jointly to see if there is something that can be developed. Then we'll be able to have that, and also at least the communal points where people get water. Yeah, and again, to also respond to the issue of the coordination, I would say that most of these, the WASH coordinations have been supported by partners. There's very little budgetary consideration from the exchequer. So there's need for higher level engagement to see if there's a provision that can come to the budgets so that we can push ahead these coordinations. Otherwise, it will be just a challenge. We have it in paper, the WASH code, the West code, but who moves it? It has been going on courtesy of UNICEF, courtesy of USAID, which was the other day declared illegal. So there is need for engagement at higher level, even at the PS, CS Treasury, CS Health and Sanitation, CS Water. So then there is that communication, and like we appreciate, even as we also transition from now the partner supported to the national, to the government supported, so that it doesn't just start at the counties, because we know it will face some challenge if it doesn't also get the involvement of these key national government policy makers. Thank you.
And finally to Sam.
Sorry, thank you. So just to say, to add to some of the things that have been mentioned, and thank you, Director from Kitui. One is communication cannot lead to community-wide behavior change. This we have to know. And as such, when we are designing our interventions, let us not talk about SBCC. Let us talk about SBC, social behavior change. Okay? Then design interventions that will change our behavior. Use communication as a channel for those interventions. Because if your focus is SBCC, you will design only communication, but communication do not always lead to community-wide behavior change. The other thing, I agree with my colleague here from education. It is important for us to pass the information through children. They are change agents. But one of the things that we need to always keep in mind when we are designing interventions that go through children is they need to be reinforced and sustained at home. The entry is at school, but the reinforcement and sustaining is at home. So whatever you do at school, make sure you have something that is replicated at home. Otherwise, you are going to end up failing because there is no reinforcement and sustaining of that particular behavior. For Dr. Opon on the issue of collapsing pits and all those things, there are several sanitation technologies for every condition. The question is,
do the community have the right information on what sanitation solutions can work for them? Then the last thing is on my people in public health. I think we've not done very well when it comes to taking out the solutions, and that is why you will find the vent pipes are inside latrines. They are saluting instead of being in the right order. They are even in the wrong direction. Did you know that when you are putting the vent pipe, it is supposed to be in what direction? Okay, not direction of the wind per se, but it should be either north or south side of the latrine. So the door should either be facing south or north, not east or west. Why is that so? Because the sun plays a very important part in removing that smell from the latrine. So where does the sun flow from and towards? East-west. So if your pipe is always along the sun path, then the latrine is going to work. But if you put it the other way, there is a time it will not be along the sun, and so the smell will always be. So what am I saying? It is because there are professionals out there who have the right information, but the right information has not percolated to where it is supposed to get. And that is why we'll always have the pictures that we are seeing. That is not the only one. We'll see more. You'll always see the wrong things being done and the communities complaining. And then they'll reject the intervention, not because it is a bad intervention, but because it was not done in the right way. Thank you very much.
Thank you very much. I have learned something new. To me, I thought as long as there is a pipe, that is an improvement. So let's give a big clap to our panel as they leave the stage. Thank you so much. The biggest panel so far, again, the size of the panel still enabled us to cover more ground, so we are most grateful. As I call Titus to come up here, that question of coordination, how is it going, how can it be improved? Titus, I believe you're the one to come and hand over to the next moderator. The moderator has been waiting for me to leave the stage, but life became lengthy.
Thank you, Gilbert, for taking us through that very important session. I don't know if I'm seeing we've reached break. I'd suggest probably we go for a 20 or 30 minutes tea break. 20 minutes, yes. Then come back exactly at 11:10. Where we'll have our next panel discussions. So we meet in 20 minutes. Okay.
Sorry, let's have order. Good morning. I think we have been given a green light to start off. They say when they are there, they are not getting so much noise from this side. So to save time, we are going to start off. And I'll start with the question, how can surveillance and data sharing prevent reemergence in border areas? And I would wish to give the first opportunity to Uganda, Moroto representative, and then also the Kenyan counterpart on Turkana to handle that question. How can joint surveillance data sharing prevent reemergence in border areas?
Yeah.
Yes. Hello? Okay. Yeah. All right. So thank you very much. So I was saying that surveillance is very key. We have to make sure that we have ongoing surveillance on either sides of the borders in Uganda and also on the Kenya. TF levels to below 10%, but we must have a scientific certification through a survey, a prevalence survey, to make sure that we are certain and document what the current levels are. So, and that is the only way we can make sure that we have reliable, credible information that we can compare on both sides. So we must have that taking place. We must have common reviews after synchronizing surveys when we must, if we have to do them. And then we must have joint meetings to review on what is happening on either sides so that we can assess the risks of whether we are likely to have the transmission likely to affect the successes from one side of the border to the other one. Yeah, and I think this is really very, very key. Thank you. Yeah, thank you so much. I'm James Ekama, is the NTD coordinator representing 20 from Turkana. Just to add on to what my Ugandan counterpart has said, think joint surveillance will enable prevention of reemergence because it has a very, very important aspect. One, it will enhance early detection and response. And also, it will enable us to have a coordination of interventions so that, like in our case where we are bordering Ethiopia, Uganda, and Sudan, once we have this joint surveillance, then it means that the coordination aspect will ensure that the activities or the interventions are optimal because we will be handling the issue from both sides. The other issue, Prof, is that it will help in shared mapping of disease hotspots. We realize that like the issue of, we have hotspots in Uganda and the hotspots from our side. Once we handle them together with the interventions, then that will prevent reemergence. Another issue is the issue of this will enable strengthen the surveillance to the pastoral communities. That has been a challenge because they move both borders. So once we do a joint surveillance, it ensures that these pastoralists are captured from both sides of the county, from both sides of the countries. So the other issue is, I think when we do joint surveillance, it is also a way of ensuring accountability. Thank you.
Thank you very much. The microphone. Before we hand over the microphone, the question was in two parts. There was joint surveillance and there was contact with the share. Surveillance is one of it. But as you said, there is no guidance. There are no guidelines from the WHO on how to do surveillance. Whether it's after regulation or not. So you have to implement it. So there was also question with the share.
Yeah, certainly data sharing is the only way that we can be able to appreciate on the situation on either side of the border. Now, unfortunately, from the routine ways of data collection and management of data, surveillance data, in our respective localities, there does not seem to be a very formal arrangement that we have that defines how we are likely to be able to, routinely from time to time, automatically get to know what is happening on the other side and what is on the Kenyan side and also on the Ugandan side. So we need to make sure that we have deliberate efforts, either through regular cross-border data reviews on surveillance, and also making sure that even in case there are any surveys that have been carried out, we must make sure that we share those reports across at any possible forum, cross-border forum like we are having here or any other. We need to take opportunity of every available occasion that we meet to discuss on the issues of the existing data at that particular point, so that we are able to appreciate the progress or trends that have been made so far. So we have to make sure that we really do something about it. It may be through sharing program-specific surveillance data or surveys that have been carried out in our specific locations. Thank you.
Thank you very much. Now, the second question I'll direct it to the Director, Preventive and Promotive Health in West Pokot, and the question is, what strategies ensure continuity of care for nomadic communities? What strategies ensure continuity of care for nomadic communities?
Thank you so much. About the care of the nomadism people, to ensure that their care is taken, or health care is taken care of, is actually to come up with outreaches. One of the things is that to come up with outreaches, because this nomadism, people move from one place to another one. So if you can come up with an outreach, collaboration between the two countries, for example, Uganda and Kenya, we can be able to ensure that their health is actually reached. Also, apart from that outreaches, we can also come up with mobile clinics. We'll be able to ensure that the people who are not settled are also getting the relevant information, and also to ensure that they change in their behavior, so that we can be able to sustain the eradication or the elimination of the trachoma. Thanks so much.
Yes, on the Moroto side, first of all, we have throughout the year a very significant proportion of mobile and migratory populations that are crossing from the Turkana or the Pokot side into Uganda, and they remain there for 6 to 8 months in the whole year because of the climate change effects on the other side. And you know, when we all plan for services on either side of the boundaries, we are always, in most cases, taking care of our defined populations. And yet now we are talking about this category of mobile and migratory populations that is not part of your planning denominator. And if nothing is done to make sure that we take care of these nomadic communities, we are likely to leave out these people not taken care of at all with the trachoma elimination efforts that we are trying to implement. So now, for continuity of care, we first of all have to make sure that we need to ensure that we map out the migratory routes, and these are well defined throughout the year. We even know what durations of time they are likely to move, where they are likely to be, because they are influenced by availability of pasture, water for their livestock. And so we can plan for services along those routes and in places where these populations can be found or located at any one time. But we need to have some joint planning together with either sides of the Turkana or Pokot and the Karamoja side. Because in most cases, like I mentioned, that usually the resources are a bit inadequate, and sometimes it is more partner support that we must rely on to enable us to provide or guarantee services to these mobile populations. And the service delivery mode is quite expensive. So within the arrangement of available local resources, it is almost impossible to make sure that we take care of these nomadic populations. So we have to make sure that we do a lot of advocacy, first of all, estimate the populations we are talking about, and then plan accordingly on what services must be provided, what will it cost us, and how we are going to deliver them. So I think these are among the strategies for continuity of care of these nomadic populations. The other one has been in order to promote acceptability of our services and also improve on the service coverage. We have to adapt to some of the innovative ways of making sure that these migratory communities are able to take up the services that we shall provide. So, and the One Health approach has really been one of the game changers that we've had to adapt, because in most cases these populations really are more moved into accepting the services and get mobilized into taking up these services when we integrate them into the animal health service packages. And I think this is really one way that we have been trying to, one strategy that we have tried to make sure that we strengthen the continuity of care. Thank you.
Thank you so much, Prof. I think my colleague has mentioned quite a lot of interventions that are being undertaken to make sure that the nomadic or pastoral communities have continuity of service. I want to add that I think we are, from our side, we are trying to strengthen the facilities at the border points so that those facilities are able to provide comprehensive care, even as we strengthen the One Health approach, which has proved to be very, very important to us from the Kenyan or the Turkana side, because these are people who cherish more of the health of their livestock, even sometimes more than their own. So you find that many activities have been incorporated into One Health, including the issues of IDs, birth certificates, immunization, and handling of the NTDs at that level. How I wish even the education sector tries to do the issue of mobile schools and the adult literacy, so that, because you notice that those kraals, the education, there are no schools in some of the kraals. So the other issue is the issue of training CHVs who are mobile, who move together with the nomadic pastoralists, training them to be able to refer the cases to health facilities. So we have such a flexible service delivery schedule, so that wherever they are, we are able to offer services to them. We are trying to explore also the aspect of GIS technology for locate, so that it can be used to locate and find out the hotspots and make sure that wherever they are, their services are being provided there. My colleague had already mentioned the issues of putting the issue of the Mormoras or One Health, as we say, into policy on the issue of its financing. Thank you.
Lightning, and the way what I'm learning from there is, for the nomadic community, whether we like it or not, we have to go to the community, because we have got several, in public health, we have got several modalities of delivering services. You either have the patient come to the health facility, or have the doctors or the healthcare workers go to the community, or go to the community and bring them to the hospital. But all of them has got advantages and disadvantages. And here we have been told the outreach modality is expensive, but it is indispensable in nomadic communities. So thank you very much. Now, Titus from NPHI has come And the question to him is, what frameworks are needed to formalize cross-border coordination for NTDs? So that I would like you to give us highlights, and also Gilbert to give us more comment on that.
Thank you. Thank you for that question, Professor Karimorio. At this moment, I know what we really dwell on is relationships, the relationship between Kenya, Tanzania, Kenya, Uganda, but they need to be embedded in frameworks so that also, and those relationships end, someone goes somewhere, we need something that the successors can come and ride on. So there are various frameworks that we are thinking about, frameworks in terms of policy and governance of these cross borders. Policy and legal frameworks also have to be in place, data sharing frameworks, and also like implementation frameworks when you carry out the implementation together, as long as together with the disease outbreak frameworks, what happens when a disease outbreak is encountered. So in terms of policy and governance frameworks, we are looking at issues like MOUs between the countries on how you are going to engage. And also, we are looking at riding into regional frameworks like East African Community, probably in the health department of the East African Community. They do have set SOPs of how countries should engage. And also riding on regional bodies like IGAD, and also bodies like African Union to cement the relationship between the countries.
No.
Titus has already given me his, it's part of cross-border. So, yeah, I would thank you, Professor and Titus. I would like to dwell on the practical aspects. I know there are a number of frameworks for cooperation, which in most cases remain on the negotiation tables. So, to bring them on the practical side, I want to give an example. For example, there is that IGAD framework. There are the MOUs between the neighboring districts. There is another framework which is cultural, which are the peace forums. They meet rather, regularly. And, among our people in Karamoja and in Turkana and this area, the Attica area, those peace forums hold a lot of weight. They are the cultural, once in a year, cultural gatherings. These are channels. They may not be frameworks, but they are good channels of ensuring this collaboration continues. Now, I would also like to pay credit to Dr. Pon and Titus. Right now, the cross-border collaboration between Uganda and Kenya is the best globally. It is the best, with all the challenges, it is the best globally. We have had situations when they present to an international audience and tell them that the Kenyan health workers would cross into Uganda and carry out treatments. And to most of the world, that is a shock, They would say, but how, But these gentlemen have worked it out over the years, ensuring that responsibility and even professional bodies acknowledge the fact that temporarily you can work under the supervision of your colleague on the other side. Now, these are the frameworks in practice. This is made possible by, again, other examples. When you would ask people at policy level, because the ministries are policy level, and you say, we are going to go and jointly launch a cross-border MDA or Trachoma. They would say, okay, I'm coming. Then they would ask, but what is the venue? They said the venue is in Kacheliba. You mean I'm going to drive from Kampala to Kacheliba? This is policy high level. You say yes. They hesitate. I will give you an answer after 2 weeks. But when they actually travel, you remember the minister for Karamoja traveling to their Mudat launch, and they get immersed into what their policy frameworks actually mean on the ground, the appreciation for this collaboration is strengthened. If they remain at national level and they do not experience it firsthand when the two counties are interacting, then we lose out on implementation of these frameworks. The last example I want to give is, during the launch, there was a launch in Kacheliba. The LC5 chairman, what's the equivalent on this side? Is the governor? Okay, he has a smaller area, but he's the political lead, the political head. When we were in Kacheliba, he told us actually he went to the primary school where we were gathered. He grew up in Kacheliba, but he's the what? He's the governor the other side in Uganda. So that shows you that the communities themselves have their own community level frameworks. And this should be a stepping stone for ensuring that the formal frameworks that are at national level are operationalized. Thank you.
Thank you very much, Gilbert. I have learned that there are written frameworks and there is unwritten stroke cultural frameworks. And the unwritten ones are more important.
There is one other framework. I remember some time back, I think around 2018, the two presidents of Kenya then, that was His Excellency
Going to different to contribute because they have a very fueling rationalize frameworks. It is for you to
powerful this agenda of financing. They
scorecard, the NTD scorecard. That is something that can be really used for advocacy because the presidents of all the presidents are the caretakers of that scorecard, and is something that they discuss at that level. So that is one of the tools, one of our most powerful tools that we can use to push NTD agendas to make sure that it's in the scorecard, and reported adequately.
Maybe just to add, now I'm putting on my NNN chair hat. There is a powerful gathering every 2 years, which is the African Health Agenda International Conference. The last one this year was in Kigali. And I have to commend the fact that here Africans are looking for African solutions to African problems and trying to push the African agenda to the top of the list. Because you have to realize a good number of global forums, they will generate agendas, and the African agenda is somewhere in a side meeting, okay? Here it is the main agenda. I think AMREF has spearheaded this kind of arrangement. Interestingly, even with us in the NNN, if we're holding the conference in Africa like this year, there is a special session on the NNN for Africa. And now this one is specifically dedicated to NTDs in Africa. So the issue is to explore the linkages between such a forum and the larger Africa health agenda, especially forums that are attended by heads of state who control budgets. Then it becomes much, much easier. Thank you.
Thank you. So I don't know whether I have still got a clear answer about the health community, East African
I think it is
community health.
It's a lacuna.
Commission. There is a lacuna. Because we can be there at Africa, but within East Africa, just like I have said, there is a health commission, which we need to, I think is a lacuna. I had never thought about it, but I think it is good for us to look into how we put ourselves into the East African Community Health Commission. Or maybe it's not a lacuna, we are high up. And so thank you very much. I think now my questions have finished unless any other member of the panel want to put an input on that question, last question, how global blocks can support financing. Any comment from any member of the panel before we close that? Or something which has come up with the previous questions?
Maybe, Professor, just to reiterate, and for those of you who are into research like Kemri, don't accuse me of trying to promote my own article. However, we did write an article about cross-border collaboration, including financing, jointly authored by myself, Titus, Dr. Pon, who was the third one? Tanzania. And in this particular article, the title was Follow the Cattle. Yeah? If somebody wants to Google it. But the argument was current financing models are governed by borders. Even right now, even with the partners, somebody can extend you money as Site Savers Kenya. It is bounded, it is limited by the boundary, okay? The challenge we are facing, of course, border migration, is not limited by the boundary. Working out mechanisms on how you can have, let's say, a super evaluation unit, or you can have joint interventions. You have to navigate certain financing requirements, okay? So the landscape is still very much within borders. So we have to seek synergy. I remember a very good case when we crossed, was supported by a different partner, not here. You know, the ones here are very good. It was supported by another partner. We crossed from Amudat to Kacheliba during an intervention. And then the question was, for the team which crossed, the question was, have you been cleared to cross? I don't know, cleared by who? Who is going to pay your allowance on the Kenya side? The reason is the allowances on the Kenya side are higher than the Uganda side. Do not give us a budgetary headache. You know, all these are bottlenecks which we do not normally address. So if you know you're going to work along the border, you may have to work this into your budgets, because otherwise the team sometimes cannot move simply because of the border thinking. The other example we had was when Samson and his team, part of his team, went into the caves in what's that place where they stay in caves? Temu. Temu, that is the other district after Kotido. Kabong. Immediately, security forces were excited by looking at the number plates on their cars. So they stopped them, asked them a million questions, but because we already had a framework, what we call the unofficial framework, you know, within a few minutes, the resident commissioner, the commissioner in charge of the district, was able to say that no, all of us in Karamoja agreed that we are going to collaborate. So there are some of the little issues I wanted to bring out. Thank you.
Thank you very much. I was asking whether there is any other member who has got an answer to that question on financing, because I didn't want to close money off. One of the main challenge, which has been mentioned by the panelists, especially from the Ugandan side, and also the Kenyan side, on the issue of delivering services in nomadic communities, is lack of or shortage of finances. And I think finances will never always be enough, but we have to keep on using the little we have most economically, and above all, start actively looking for more. So money, which I call vitamin M, and lack of it is vitamin M deficiency, will be always there. So now I give this opportunity to the participants to put their question across to the panelists. Anybody with another, I will not call it again a microscope.
Yeah, thank you very much. Mine is on the strategies proposed for continuity of care in the nomadic communities. First of all, outreaches and mobile clinics, these are temporal. And they only work in areas where the roads reach. They cannot work in areas where Trachoma begins. So I would propose that maybe we would revisit the strategy there, because an outreach, mobile clinic are temporal. I remember when the two presidents came to Kobebe in Uganda, they proposed the construction of health facilities on the what? On the cattle corridors. And they also proposed the construction of facilities close to the border. So I believe this would be a better way to go. Then the other one, somebody mentioned the issue of strengthening the border facilities, but how far are they from the border? Go to Lokiriama and look at how far is Lokiriama to the border. You come to Uganda side, come to Nakloro, how far is Nakloro from the border side? Then when you look at the distance between the facility and where the pastorals are, how long are they going to take to walk there? Like in Uganda, walking from the cattle, let me say the cattle grazing areas to the facilities is over 30, 40 kilometers. So how long will they reach there? So this makes health seeking an issue. So I would propose that since we are having chiefs, we are having high-level representatives from ministries, they should look forward for the way how facilities are constructed in this area. Thank you.
Just continue.
Thank you so very much, Professor Karimorio, and the panel. I think since we began the discussion, there is something that is not coming out very strongly, and I thought it would come out particularly from the panelists, matters to do with embracing technology for surveillance. Probably I can share as more experience I have from where I've worked previously. I had an opportunity to work in Moyale, and we had a very strong border health committee between Ethiopia and Kenya. And I happen to be the chair. I'm just wondering, because how we used to go about it, we had a partner, yes, from the UNICEF who was very strong in issues of AI on surveillance, particularly because of the nomadism of the community. But I'm just wondering, like West Pokot, my colleague has correctly put it, same as Moroto, looking after people who are running after cattle. I'm just wondering for how long, having been in this independence for over 62 years or 60 years, that we shall keep actually tracing people. Is it possible we now look from within and see how we can embrace the technology and be able to embrace it in the surveillance system, particularly in the sensitive or the hotspot areas of the border? Number two, maybe from Moroto and West Pokot, I'm not sure, maybe you could just share your personal experience. And I did admire what our colleague from Uganda said, that I think going forward, what we need most is joint planning. I was very happy to hear about the resource sharing policy or an agreement that was done somewhere between the two countries. But then, I'm just wondering from where I sit, how well is the border surveillance, and what could be the challenges that we are having when we are implementing whatever activities that we are having, particularly on the issues of border surveillance, that possibly can help us learn and rerun. Because the little experience I have is that we may have embraced a very traditional, for lack of better word, surveillance system, which sometimes may actually limit us in terms of, getting the outcomes that we are looking for. So what exactly is the experience between the two bonders in terms of the surveillance, and exactly what are some of the challenges over and above the issues of migration and the mobility of the community?
Any response from the panelists? I have heard West Pokot being mentioned. I've heard Moroto being mentioned.
Okay, thank you very much. Maybe let me talk about nomadism in the area that within the borders. The bigger issue why we still have nomadism is because of drought, and if we would make these people to settle, it could be better. But now we cannot do a land demarcation in an area that's full of drought, and these people are cattle keepers or livestock hearers. So the other issue is about the insecurity. The issue of insecurity maybe until it is enhanced, so that we'll be able to have people to settle and have to be able so that services can reach to the people. Thank you.
Yeah, thank you very much. Maybe before I come to the question on how well border surveillance has been on both sides, I just wanted to get back to the issue of how global blocks could make a contribution. One thing that we have not mentioned here, actually, I remember yesterday Professor brought it up, is that I think often the regional blocks look at all issues to be addressed from the economic perspective. And that is what sells. And it means that even for us, we need to prop up our NTD-related interventions from and yet, the communities that are being looked into by the regional blocks, especially those cross-border communities, the migratory communities, have got very peculiar economic-related burdens. They have serious human development indices. And we need to bring up our agenda along those lines or perspectives. We must take this kind of discussions to higher levels, to the levels of the ministers and the rest, so that we can find a window or opportunity on how all these things that we discuss in our meetings like this can find a way into those regional level discussions. Yeah. And then coming to what my brother there mentioned on how well the border surveillance on both sides has been done. We earlier on alluded to this already. First of all, across the borders, we have very parallel disease surveillance mechanisms with very limited opportunities of sharing information, sometimes even very limited opportunities of alerts that guarantee immediate response, on either side of the border. So exception of only a few particular public health challenges, like related to maybe viral hemorrhagic diseases and the like. But for all the rest, for the NTDs and so on, they are so silent. So we need to see how we can actually make sure that, we make these issues that we discuss very important, and that their surveillance actually is key on either sides of the border if we must control. So in other words, we need to have surveillance technical working groups on either sides. And this should be a way that we can make sure that we share information at that level, at technical working groups on both sides. Yeah, it can be a guaranteed way we must have. But as of now, sharing surveillance information cannot be tagged onto any surveillance structure that we have on either side of the border. Our health information systems of Uganda and Kenya are totally, they don't communicate to each other at all. They are totally independent, and there are a lot of issues on surveillance that must be actually transmitted across the borders for immediate public health interventions or for sustainability of public health responses. Yeah, accordingly. Thank you.
Carry them out. So if you want us to hurry you.
Yes, thank you, Prof. So,
That was great. That's a new one for me, the locomotive clap. So we still on the same line of cross-border. We move on to the fifth panel discussion. This is on leveraging on One Health for integrated trachoma discussions.
Thanks, Watitu. Before we move to the fifth panel, there's a presentation on One Health. It comes before One Health. So, yeah, when you're ready, please come to the podium.
His Excellency of Baringo. Today, we have His Excellency Minister of Health, Baringo. To welcome him, I'll give one of the chief officers to introduce the team.
Thank you, but I'm not a chief officer, but I don't mind being one. We are privileged to have our chair, health committee from the Baringo County Assembly, Honorable Locorio, and our CC in charge of health services in Baringo County, Honorable Sirma, Dr. Sirma. Let me take this juncture to welcome Dr. Sirma to make his remarks and say hi to us. Then subsequently invite the chair health committee of Baringo County. Simona Baringo iko mbele. Yeah? Baringo is leading, eh? Thank you, Karibu Waziri. From the governor, chair health, Waziri. It's full house. Thank you.
Thank you, Director. I may not know everybody here, but all protocols observed. And let me say good afternoon. As you've heard, I'm Dr. Solomon Serman, the CEC, Health Services Baringo County, a county of great diversity. We hold all types of everything in Kenya and Baringo. So it's a pleasure. I was not able to be with you yesterday. I had an appointment with the County Assembly of Baringo. Mnajua hiyo watu ni hatari, wanaweza kuimpeach watu be present. Otherwise, nevertheless, I've joined you this morning and I've seen the progress is going on well. And I want to thank Red Olos for the achievement we achieved so far in Baringo County, in our 4 sub-counties, that we have actually almost, or I think we have eliminated Trachoma. And we are continuing, and I'm sure you have been assured in terms of sustainability. We are planning to do integration and also have a line budget for the same. Otherwise, I don't have much to say for now. We'll continue working together, we'll exchange contacts, and we'll be in touch. Otherwise, the visitors from Uganda, karibuni sana, Kenya, on behalf of the 5 counties that are here, although I know my colleague from here, I'm sure you must have talked yesterday. Karibu North Rift. You is interesting traveling all the way. You've crossed to North Rift. Karibu and you're welcome. I know nobody, let me represent for now Zingishu County, now that they are not in East Forum, that the CEC is a friend of mine, and we have the blessings of the county of Zingishu. Otherwise, asanteni sana na Mungu abariki. So let me take this opportunity to invite my chairman health, County Assembly of Baringo, who has been working I want to welcome Chair Health, Baringo County, to give his remarks. Somebody, they have really been very supportive. We don't have issues uko upande wa health. That's why our department is stable. Asante, karibu Chair.
Thank you. Thank you, Waziri. Good afternoon, everyone. Yeah, my name is Mheshimiwa Locorio. Those that are coming from Turkana, you may associate yourself with me very closely. But I'm a token from Baringo. I chair the committee in the County Assembly of Baringo. I thank you so much to the organizers of this meeting, and we want to appreciate on behalf of the people of Baringo, and thank everyone who has come here. I am happy that His Excellency the Governor of Baringo was here with us yesterday, and I'm sure he represented His Excellency the Governor who was in Kishu, and want to thank the county government of Kishu for welcoming all of us here. I want to really appreciate what we're doing and what we've been learning, and say that I benefited and I'm still benefiting from this learning session. I was impressed with the last two topics that was to do with the migratory routes for the nomads. I'm a nomad myself. And I was impressed because we were discussing these guys and myself. And again, very happy that Waziri has declared that Baringo, we are doing very well in terms of tackling Trachoma. I'm happy. And that still we were able to discuss these unwritten kind of MOUs, the traditional ones, and I really want us to take that direction, and particularly for those of us that are living in Baringo. Baringo has everybody in Kenya. Baringo County, and that is why we are the county of diversity. We have the Turkanas in Baringo. We have the Pokots in Baringo. We have the Kikuyus. We have the Tukens. And we have a whole Republic of Aror, where I come from. So you can imagine. and that is how serious Baringo is. And indeed, we want to appreciate the learning, and we'll go back. As a committee of health in the County Assembly of Baringo, we will always ensure that we have a clear budgetary line, and as we've been supporting all the time, all the programs. With this, and we would have all of us wish to join you and learn. Thank you so much. We will keep talking, and Amapu Baringo, allow me, the person chairing this session, to really ask all the Baringo ladies and gentlemen to be upstanding. Dakika moja tu, tusimame watu Baringo. Basi hii ni heshima kubwa sana, si mujaribu kutupatia makofi ya ukweli. Asanteni sana, be seated. And to our good friends from Uganda, karibuni sana pande wa Kenya, karibuni sana Wasinkishu. And the organizer and the partner, I would want to plead with you that the next meeting in Nyorosho Baringo, ndio mkutano wa Meru wa Baringo, watu wa Kosi wenye wako Baringo, and all these people, and the people from Uganda will really learn and really understand the beauty that is in Baringo. Asali natural kutoka chini. And now, of course, you can forget to mention the salt mbuzi choma. Free. You should be ready to eat mbuzi yako peke yako pale kando. So that's the beauty to bring us. Thank you so much. God bless you.
Maybe you should appreciate our child in a special way. You can do that. Thank you.
Aha, yangu zote zimechukuliwa, hata ile ya locomotive that has been always But I want us to stand up when we are appreciating him. Yeah? It's sort of an appreciation and what do you call it? Commemoration to Baringo. Tara tumpatie ile ya Nyayo. Good. That was good. Now also, we are also happy to be with us here, the also chair of the health committee for Embu. And for that, I request Waziri to introduce him and let him.
Habari zenu leo. Sawa, mimi sina budi nitachukua nafasi hii niwakilishe ndugu yangu Mheshimiwa Job Itumo, Mheshimiwa wa Mwea Ward, na ndio chairman wa kamati ya health katika bunge la jimbo la 14. Asante sana ndugu yangu Job. Karibu.
Good morning. Oh, it's afternoon. Good afternoon. Yes, good afternoon. My name is Itumo Job, MC Mwea Ward, and also the chair Committee of Health in County Assembly of Embu. First, I want to thank the organizer of this organization, because in terms of invitation, you have invited both the executive and the county assembly, whereby the county come in Monday when it comes to resource allocation. Because when you get involved in this one, when we want to do resource allocation, we shall support the budget from the executive. So you have done a good job. The other thing also I want to say is about Friend Hollows. We have worked with you. They have come, the big number, and also we appreciate your governor was here yesterday. She's a good gesture towards what we are doing here under the land we are taking. We also come with the team from Embu County Assembly and also from county government. And I just want them to just stand up. We recognize them. Chairman of Health in Baringo County, you have a very big team, but you are not gender sensitive. Pale wamefinya wamama sana. Wamefinya sana. So next time, angalieni mbalance hapa na pale kidogo kidogo. Ketini chini. Kwa moja ni yule lakini amefinya sana. This great man. As I went up, Chairman, si unasikia hata analia, na ukiona akilia tukiwa hapa, akiwa nyumbani atalia aje? Thank you so much. It was just by the way. What I want to say, which will be coming from the executive. Me being the chairman in the county assembly, I will make sure I support the budget allocation so that also we may do away with this Trachoma. The other thing I also want to thank the organizers, because these are small gaps that you see they missed in national government and also they miss also in the county government. So you are coming in handy so that also you may sort them in a very good way, which you have done. Because if you see the budget allocation in the national government, you don't see this budget of these diseases which affect the most marginalized communities. So what we are doing as our development partners, we appreciate what you are doing. we shall continue to engage so that also we may have good health to our people. Thank you so much. Thank you, Chair. Can we have a volunteer to lead us in appreciating the chair from Embu? Jen, you're looking at me. Can you help us appreciate the chair from Embu as I invite One Health? Jen, lead us in appreciating the chair from Embu. I had a good reason why I insisted on Jen to lead us in the appreciation. Allow me also to recognize the presence of the CEC of Turkana, who is with us. We will have a special session for him to speak to us in the interest of time right now. So that basis, allow me to invite One Health to take us through this Kimormor model in integrated trachoma intervention. Thank you.
Yes, thank you so much. So my name is Rotich Robert Kipkorir from Turkana County Government. I coordinate One Health activities. And today we will share our strategy with regards to trachoma intervention, how best we can integrate this into One Health. So in Turkana County, we have an established County One Health unit in existence from the county level up to the community level, whereby we have structures. We have the County One Health Unit Secretariat under the leadership of the CEC, the three key ministries, that is the Ministry of Health, Veterinary, and Environment, and including even Water Ministry. So those are at the leadership level. And then we come at the coordination level, where we have the co-chairs. Co-chairs are the directors of those ministries that chairs One Health activities. Other than that, we have One Health focal person from those three ministries again. So I come from Ministry of Health. I have a counterpart from Livestock and a counterpart from Environment. So we jointly work together in addressing these issues of One Health. So in Turkana is a bit unique. Other than what we know, health, environment, and livestock, ours is a bit more than that. And that is why we refer to as Kimormor. It basically means all together. So other than the three key departments, as we all know, One Health is a collaborative, multi-sectorial, and multidisciplinary approach in addressing health-related issues. And we aim to address shared needs at those interface, the human, environment, and animal interface. For Kimormor is a Turkana word meaning all together, and other than the three key issues there, we do also the social issues, including providing ID cards, SHA or SHIF, we do registration of those things, and also water issues, birth certificates, among other things that we do in addition to the definition of One Health. So if we do this, we can see from the far right what One Health related issues are. AMR, the issues of environmental health, food safety, NTDs is part of it. and also zoonotic diseases. If we approach this in terms of One Health, we will be able to improve environmental health, prevent zoonotic and vector-borne diseases, reduce antibiotic-related infection, and also ensure food safety. So in summary, that is what One Health is and what we can achieve by addressing the issues of One Health. Yeah. So for Turkana, we have a strategy document that guides us, and it was launched the year 2022 by His Excellency, and that is a tool that we are using to address issues of One Health in Turkana County government. So we have the strategic objectives, which are 3: to strengthen implementation of One Health approach. Basically, this is the coordination level. And then the second one, the issues are, first one is where this Kimormor lies as a strategy that we are using. And then the second objective is strengthen consultative surveillance. I think we've been discussing this. Response, prevention, and intervention to safeguard One Health priorities. So this One Health is not only from health, but across the 3 departments. And then the other objective is promote applied research using One Health approach. This is the document that we have, and that it guides our operationalization. But we are in the process of having a policy and a bill so that it can ring fence even resources so that we can sustainably address issues. So Kimormor, we go now to specific the Kimormor model. Is this integrated activities for all these issues that we've said, and we normally go to population that are underserved or unreached, or the pastoral communities. So the model began way back 2017. That's where the data we extracted way back in 2017. But initially, before we formalized the One Health in Turkana, it used to happen. We had a partner called AMREF, and they used to place containers along the migratory routes. So when the animals and population passes that migratory route, they could get the services both for human and animals. But now, from 2017 is when we did this Kimormor model. We'll be doing circles, over 15 circles, and it targets the Turkana community is a bit large, 77,000 square kilometers with 264 facilities, and borders our neighbors here, both Uganda, South Sudan, Ethiopia, even West Pokot. So our pastoral community accounts for 70%, and that is the number. And Kimormor began 2012, 2017 is when this initiative began. And the aim is to access the underserved, unreached, and migratory population along the border. So that map shows the size that we've done these Kimormor activities, and it borders Uganda. I think Urum borders Uganda, Puch areas, which include the... So justification, as you can see, the migratory route in that map, now we have Uganda and South Sudan, the top. And we say that disease does not respect boundaries. Our population moves with the animals, and those are migratory routes where these communities go in search of pasture and water. So, but for us, we follow where they are. And we can see over 10% of our population cross the borders. So that is the need as to why we need this service. So the objective basically is to sensitize community members, to enhance surveillance on priority issues, offer human services, vaccinate, treat, deworm livestock, and offer extension services for livestock, to increase the uptake of social health insurance or services, civil registration, and even the ID, that is the NRB. And then also the issues of environmental conservation and protection of range lands, and also to advocate the issues of water safety. So this is for the period of 2017 to 2024, and those are the sub-counties or the units that borders the international boundaries. And this we included the humans and livestock living in those areas at that particular time. And the strategy is to offer this the whole continuum of services. Sorry, back. So for human health, I think that is just the whole continuum of health services. For animal health, number of livestock, household reach, and the pastoral reach. Environmental, we do waste management, disposal at civil and community level. Hygiene also, and also includes tree planting. While we do this Kimoromor, we also take trees, we plant, and also we advocate and advise the communities to preserve the environment. Civil registration is just issuance of birth and death certificates. National registration is the ID cards. We understand that these people, once they go, it's very hard for them to come back unless the animals are back where these services can be found. And then also for us, the chief, the health insurance cards. And those are the data using the tools that those 3 different ministries are using so that we can develop this. So this will to enable to tell us how far we've reached to these people with these services so that they can benefit from them. Next. So before we do Kimoromor, we normally do recognize and visit, because these people, they are never static, they are always on the move. So you cannot plan today and go, you plan ahead like a month or so. So you go meet the crowd leaders, the chiefs, the assistants, the village admins, so that they can tell you where are these population and at what point in time can we access them. If they're in Uganda or they are somewhere within our borders, you use the crowd leaders and just inform them we are planning to come to bring these services to you. So we agree when can we meet them at a particular point, mostly at a water point where animals converge to drink water so that these communities can come there also. So we do that and assess those issues so that it can help us to go and reach this community. So for health talks for that period, as I've said earlier, 70% are pastoral. We've not been able to reach a huge number, but it's something scalable. Been able to reach less than 2% of that population because it's not something high intensive or like it's pegged on resources. So when we get resources, we do this, but it's a good approach. So for that period, we've reached that communities with the health messages cutting across all those services. Yes, there's something called a tree of men. And this tree of men, because once the population gather, you have a session with purely men, and there's a women section. So this basically is to discuss the social determinant of health, other than the livestock and human health, other issues, including water, transport, and everything that affects that village. So from this, you can be able to get to know the gist. It's just a parliament at that community level where the issues are transacted and acted upon so that the men can advise what are the priority needs of that particular community. So for environmental conservation, I think that is one of the sessions that we had. The former US ambassador here, planting trees. So part of this activity also is to encourage the communities to sustain the environment and also conserve by planting more trees. And we've been able to plant around those number of trees. Yes. So immunization services also, so we, as part of the activity, and also like the HPV virus being offered to the population. Nutrition services, the same thing. From that period, I think that has been what we've achieved. ANC also, but of key importance is the next. Yes, the eye care services also is part of our activity. And since then, we've been able to see up to 387 clients getting these services for eye care. For animal health, we do also vaccinate, treat, and advise the community members on the best practices to make sure that the animals are healthy. For NHIF cards, since then we've been able to reach to this specific pastoral community to offer them with this social and health insurance card so that they can be able to access services at their nearest facility. And then also registration of ID cards. This is the most sought service when we do this Kimormor, because we go as a complete team and just process everything for them so that they can even access. You find a man over 70 years who have never had an ID card. It tells you that they have never accessed any government services. So this is an opportunity for them to access this very important documentation. Birth registration also, we offer during that exercise for people so that they can even use them to get other services. The wash component, I think we talked about this wash component. We also offer water treatment chemicals, the jerry cans, and even give a health talk. Other than that, this is a latrine. Before we go, this is a latrine purely for the nomadic pastoral community, and we encourage them when we go there because where we meet there are no latrine facilities. So as a requirement, we encourage them that we will be here for a period of 5 days. We need a latrine in this place. So they go and construct, and later, because it's something that is there, we can also, they can use even after the services. So this is just an example of a latrine constructed in anticipation for this Kimormor activity. Some of the partnership that we have collaborating with us so that we can see this through, the National MOH, the Turkana County Government, IRC, AMREF, Kenya Red Cross, IRC, and basically those are the issues that they are supporting us with for One Health at the county level. In terms of budget, this is just a cost benefit analysis for Kimormor. An example is the one circle that we did for 10 days. The cost, that was January, was around 7 million. But when we do cost benefit analysis, if these other departments went independently, they will have used more than having a combined approach for these services to using only a cost of around $2 rather than $8 when we do individually. So that is the PL outputs budget for and source of fund. So for health in Turkana County Government, our yearly budget is around 45 million, which includes this Kimormor activity. Gaps, I think we have this strategy, just to highlight. We are in the process of developing a policy and also having an act passed by the county assembly so that each and every department can have a portion or a percentage of ring-fenced funds so that it can support this One Health. Best practices that we've had with this is joint planning, mobilization, and implementation of this activity, prior visit to going these places, use of key resource persons at the community level, dialogue, and then multi-sectoral coordination, cutting across all the departments, security services, and also media coverage for visibility, and also the leadership, the political leadership. They're embracing this Kimormor model because it targets the people most in need. And then citing of the activity where these communities can converge. We are not going to facilities, but where they are best placed at that particular point in time. So recommendations, I think the visit is very key, and then for community mobilization, prior mobilization, so that you can get numbers to make these communities replan their migration to wait for us, because they had even to wait for you. They tell you, just find us at a particular point so that we can get these services. And then for health, I think, yes, some of the areas that we look that we are consistently improving so that we can have a success. For animal health, the crashes. The challenge was these crashes, especially for the cattle. You know, to restrain them is very difficult. So to have these crashes placed along the particular area so that it is easy for vaccination and even treatment. And then I think the low uptake, I think there is need for more advocacy to community so that they can have access to these services and use them maximally. The other issue is the ID cards and birth certificates. As a policy, someone has to pay for it so that they can get these services. So this is a challenge because it's a policy. And these people, when you get them at the village, the remotest areas, they have nothing to pay for it. So you need to work to solve this issue. So that is the end. But I have a short video on the same, around 4 minutes.
And the one else chapter is a multi-approach where we are attending responding to the issues to the human, especially the community. One health strategy in Trachoma we call it Trachoma. The one health strategy is a multi approach where we are attending responding to the issues health, both to the human, actually, especially the community. The one health tomorrow is under the blessing of His Excellency the Governor, is well aware and his blessings given us the opportunity to proceed with one health unit, which is the main within the 3 departments. Also humans are not able to get diseases. In the same perspective of One Health, we collaborate with our human health counterparts in ensuring that we control zoonotic diseases, which are normally transmissible from animals to humans. And at the community level, surveillance is being done jointly by the community health volunteers and the community disease reporters, whom we normally train on aspects of One Health as far as zoonotic diseases are concerned.
Kimormor approach is very important to Loima sub-county because Loima sub-county borders Uganda to the west. And the pastoral communities from Loima normally migrate to Uganda looking for pasture and water. And in the recent past, there has been conflict in Uganda, and this population came back from Uganda to Loima. And this Kimormor is a strategy that will help us get all the focus for immunization, and also all those pregnant mothers who have not received antenatal care service.
So thank you very much. Back to chair.
One of the key lessons I'm taking home is language is diverse. Language is diverse. Where I come from, yeah, if you move the K, I, and then you add MA, you call it Mamormor. Yeah? Who can tell me what that means? Call it. You should know that. Mamormor is something warm. And if you split mormor into one word and you have more, is happiness. Yeah, that's how diverse the language is. From look of things, thank you, Rotich, with that presentation from Turkana on Kimormor. Turkana Kimormor is all together. It's an holistic approach to delivering services. Okay? Yeah, which is very good. And I see eye health is in it, there's wash in it, and of course by extension, we can also ensure that trachoma is also integrated into Kimormor, right? As part of the wider integration of trachoma interventions within service delivery. Okay? Can we appreciate Rotich? Not that way, not that way. I'm looking for a volunteer. Nakopil. Hey, you are anxious. You're looking forward to it.
I want to say thank you very much. Rotich, that model for Turkana, we will just copy and paste it. I know that. That is along with Pokot and Karamoja. Purely animal vaccination wanaruka jana sasa. Sitasahau, tutakupea yajayo kwa sababu najua origin ya Rotich lazima, hata kama ulizaliwa Turkana, lazima tengine kutoka Baringo kidogo ama pwani ya Baringo. So tutengeneze ile kadu yake aishi. Hiyo ni original na kuna juice. Aya, nikisema moja mpaka nijamaze, nitasema tenda moja, mbili, tenda, funga na usikue.
Thank you, Nakopil. It's lunchtime, and we still have a number of panel discussions to cover. Actually, 2 to cover, and I want us to agree in terms of the timing. about 20 minutes past 1. Can we be settled by 2:10? Is that agreeable to everybody? Yeah, so let us take our lunch and then settle by 2:10. And we have our bishop in the house. I'm or imam. Gadi. Bishop and Gadi as well, because we also have Jamal from the other faith. Leaders in a word of prayer and bless the lunch for us.
Thank you. Na tuombe. Baba Mwenyezi Mungu, tunakushukuru wakati huu. Asante Mfalme kwa sababu upande huu umetupeleka. Wakati tunapoenda kwa maakuli, naomba ya kwamba ukaweze kuitakasa na ibariki katika jina la Yesu Kristo tunaomba tukiamini.
And the panelists are not here. And then we look at the key learnings, very high level key learnings from the panel discussions from yesterday. That would be a do that in the next 2 hours. 2 hours the meeting. So allow me to usher in Titus, who will be moderating the next panel discussion that is on leveraging on One Health for integrated trachoma interventions. Part of our work has been done by Rotich when he presented on One Health. And we're just building on that in the next 30 minutes, right, Titus? So may I invite the Director of Veterinary Turkana? Do we have the Director of Veterinary in Turkana? Rotich? County epidemiologist from Baringo. You stand in for him, take the podium. One Health focal person from Turkana. Okay, Rotich is there. Okay, and then MOH Uganda. We'll take the, okay, good. Site Savers, Uganda. Okay, take us.
Okay. I don't know if anyone can get hold of Rotich because he was the main. Karibu Rotich. Until he comes. Thank you, and thank you for the presentation. Set the ball rolling to this important panel discussion, and that's why we're waiting for you. But the first question is to the whole group. It is sort of a zoonosis question. I had it being also discussed in the documentary, where they were asking about the interlink between disease transmission from humans to animals, or animals to humans. How does the One Health approach really help to counter? So I'll start with Baringo, or you can give some of your inputs on that.
Thank you. Actually, the principle behind One Health is basically holistic approach, cutting across all those sectors. And this is a strategy. One Health is a good strategy, and it's basically an integration strategy. In terms of the link is there. You know, we are basically social animals. So whatever affects our animals in the environment are the same either factors or drivers affecting our activities across. That is from the environment. Starting with the environment, the human population, the animals, and basically, if
the intervention should just be tailored to the same strategy. Whatever you're doing for the humans should apply. If it doesn't apply, you can modify for the animals as well as the environment. I think it's all about surveillance. Then surveillance can control the animals, the environment, which is doing the hygiene, which is actually broadcasting. In terms of collaboration, we should cut across, either in terms of the sectoral, in terms of interventions, to be targeted. In terms of community engagements, that don't go beyond the humans, which can be adopted. Yeah, and even in terms of M&A frameworks. Yes, thank you.
Wonderful. Those are very good responses, Chief Officer. And from the responses, I'm very confident and happy to what Nakopir said. Ile nafanywa Turkana watafotocopy. So I think we are well in the right track. Thank you for that. And to Uganda representative, your question is what governance mechanism enable multi-sectoral health, agriculture, and water collaboration? What governance mechanisms are there to enable that collaboration?
Yeah, thank you very much. I want to take it on from the kind of organization that we have in Uganda. We have what is referred to as at the national level is what is referred to as the National One Health Platform. And under that National One Health Platform, we have some key ministries that are members of the One Health Platform. We have Ministry of Health, there is the Ministry of Agriculture, Animal Industry and Fisheries. We also have Ministry of Lands and Water. We have Uganda Wildlife Authority. And these are coordinated by the Office of the Prime Minister. And you know the Prime Minister ideally is the leader of government's business. And you have the academia in there, a number of development partners, and so on. So it is a very wide bracket of that cuts across multiple sectors. Yeah, and so at that level, it cuts across a number of areas concerning resource mobilization, influencing budgets at the national level, guiding policy, and design of policy guidelines that trickle down to the subnational level. Now, at the local government levels in the districts, we are expected to replicate the same. So I am supposed to work at the district level with other sectors that fall exactly those line ministries. And we must have some proper coordination with the colleagues under agriculture, animal health, water and environment, post wildlife authority, and so on. And we have a well-disseminated policy, which we are supposed to be implementing in the guidelines. And we have the national training guidelines, and we also have guidelines that enable us to develop One Health work plans at the lowest level. So ideally, that is how we are able to try to connect with several other sectors.
Yes, please.
Even the same strategies also cross-cutting. I believe it's governance mechanism across. Maybe now in Kenya where we have the 4 units. I was thinking, can we have a CEC done about the 3 departments or 4 departments so that we can integrate all of us? So we can have a sector also cutting across all these sectors. Food for thought, but it's possible. We can also develop strategic plans which are actually cross-cutting, which integrates all the sectors. And maybe when, like I saw from it's called the Ghana model, tomorrow, it's more of an integrated community cessation strategy, which I think it can be applied across. And I want to appreciate Nakopir. It works. It will work. And we can continue to talk about Ghana to integrate and it will bear fruit. Thank you.
Yes, maybe in addition to that also is, yes, tomorrow morning works, it is scalable, and it has some cost benefits other than one department going and doing the same thing, the other department. So in terms of cost, it has benefits to the community. So maybe in addition to the governance structure is also the shared surveillance data, because we know surveillance gives information for action, and this information to reach the decision makers, we need to have data so that it can improve the governance system.
Honorable, now that you have the mic rotated, that question is for you. How can the livestock or environmental hygiene reduce trachoma factors? How can livestock stroke environmental hygiene reduce trachoma factors?
Yes, thank you so much. So as we've seen earlier before in the model, it's across those services that we offer. And one of them is environmental conservation, and also the hygiene, personal hygiene. I think from what we saw by construction of the latrines, it directly affects the cleanness of that population, and also the area in terms of how this trachoma can affect someone. In terms of environment, I think having a clean environment, having the community to know what they should do to make sure that they are clean the face, washing as earlier shared, so that the disease transmission can be interrupted or reduced to manageable.
That's great. So now the last question, and I'll give an opportunity to each of you to answer. This is on the lines of policy. What policy changes are needed to embed One Health in trachoma strategies? What policy changes are needed to embed One Health in trachoma as a strategy?
Yes, maybe I can start off. So now that we are transitioning this trachoma, the policy, one of it is maybe integrating One Health into the Trachoma National Action Plan, so that the One Health agenda or the Trachoma agenda can be achieved through One Health, that is by having in existence the National Trachoma Plan. Also include also the monitoring and evaluation aspect to human, both and animal conditions, to each policy. And the other thing is the how the funding should come along so that we can realize this, and joint financing mechanism through maybe donors and other stakeholders so that we can realize this. Lastly, maybe aligning ourselves now that we are a community to other existing maybe East Africa, the INCAT laws, the AU laws, so that we can be embedded into that, so that we can realize this. Thank you.
Your points are well taken.
Yeah, thank you very much. I think, first of all, there is need to have One Health institutionalized in our government systems, so that it does not run like it's more of a project on a project mode. You saw even from the video shown by the person in Ghana. Most of the support, I think, was from several partners. And I think there is a need to see how we can own it up as government establishments, so that it is part and parcel of our routine work plans and budgets. It's factored in the government grants that we receive from the center, and I think that would be the most sustainable way to go. And the other one is, I think, I don't know if in Kenya you have a national planning authority, or at least such entities that guide planning at subnational level. I think One Health needs to be factored in our planning guidelines, so that you know, it is a system issue from the word go. I cannot develop a work plan at my level without factoring in all aspects of One Health. And there must be a provision of the related sectors that fall within the One Health arrangement or working framework to actually harmonize their work plans, so that at the end of the day they build synergies. What an environment should actually be value addition to what health is doing, should be value addition to what the other sectors are doing, something like that, so that we have a self-sustaining working arrangement within our own system. Yeah, I think that is, and then
all of us together work together and reduce the cost. The two, we need to strengthen One Health and actually scaling in community involvement. Like now, CHPs. That is, this is not in the Kenyan perspective. We need to package for them so that we can build up on One Health, bottom up, from down upwards, and I'm sure it will have a big impact going forward. In terms of policy development, we need to integrate One Health into wash programs, hygiene programs, livestock programs, water programs, and it will have a lot of impact. Lastly, on socioeconomic factors, especially matters Trachoma. The federal approach can be enhanced, just like the way Trachoma has done. To be a good political involvement in this. And I saw the governor's name being named in the community. You know, buy-in, it's a very good buy-in, and actually the whole community will hold. Then now we put it in our structure and apply it appropriately.
We have opportunities like in Kenya where we have SHA now, it's called SHA or Chief. That's called it Shisha. We can, this is our economic enabler, and actually ride on it to make one as integral part of it. Double surveillance, I didn't talk about it. But sectoral collaboration, which is very key, where we, it's more of a now governance, where the ministry, the key ministries now, both national, like in Kenya National, and then involved with our partners, and even up to building academic institutions. I'm sure Professor Gad, Chifida, and Nairobi University can play a role, or any other institution within our setups can play a major role in all this for us to eliminate. Thank you.
So much, Chief. Those are very lovely insights. At this juncture, I open it up to the floor in case you have any questions or need any clarification from the panelists on the matters World Health. This now, the conversation is going on, and we will pick it up from here. Start with Dr. Fon, then we go to Professor Karimoni.
Thank you so much, the panelists. Thank you. Guys. Especially in the cattle corridor, there's usually challenge with water for animal use and water for human use. It's a big challenge. Sometimes leads to conflicts along the in the water for, and you don't cater for genocide. And where is the balance in that? Thank you.
Okay, I hope you've noted that question now.
I'm not used to talking like that on them. Yeah, mine is just a thought. Because we are talking of integrating trachoma activities into one head. One of the panelists has given us a very good instance as a starting point, that now we are translating. Which means not all activities, because some activities have to be given at household level. And it is good to look at all the trachoma activities and take a checklist, and that I will throw the challenge to the Ministry of Health and the county government. In the old days when we were so few, and we were thinking trachoma control as a vertical program, we had a saying that too much integration leads to disintegration. You may integrate so much until you disintegrate. So it is good to look at which component are integrated. For example, I have got an issue like where there is a NDA. We had that, we have got 3 evaluation units. We have got Western Turkana, we have got Narok West, Narok South-Basically. NDA, I don't think that approach can work. And any other places where it will come, because it requires services at the household level. The other thing is, TT surgery it can work, but we need to be told by people from Turkana. So yeah, it's from Turkana because the people with the TT some are very older. Are they able to make the very elderly to the place where you are doing services? Because you can connect all the TTs and do the TTs in the questions, Baringo one was central place. If we come to F&D, that is the easiest. Because one health promotion, that's a very strong thing for health promotion. Health promotion can be done 100%. So I think we need to look at the checklist, say these are the trachoma interventions we are giving. This is our need, and then see what works and what can be integrated. Thank you very much.
Thank you, Prof, for jogging off.
Like now, I'm making more water available so that you don't confuse the animals. So some of the cultures are actually tied to unavailability of the resource which is water. So I think going forward to public participation, let's invest appropriately. Let's have water as a priority, especially in Tiati and all these trachoma, so that even as we come with strategies, we are not competing for this scarce resource, which is actually what is bringing all of us together. In terms of Karibudio, I have to appreciate your input. I think even this integration of one should be diversified. Like in a county like Baringo, which is a diverse county. At household level, and in terms of the governance, at county level, what we're able to integrate at national level, or even at regional level, or what can even cross county, and even cross country. Now that we have Trachoma across Kenya and Uganda, we tailor the One Health and integrate appropriately depending on where it's applicable and where it's not applicable. Because I believe there are areas where these surgeries can be integrated as One Health, but others in other places cannot. And for the FE, where it is interpretable, we can use One Health. We just diversify our approach. Thank you.
So maybe in addition to what colleague have said, for TT surgeries during chemo, I know that is not done, but it is just review and a follow-up of cases and schedule, so that these people can be scheduled for facilities so that the surgeries can be done. Of course, the environment where this goes just under treat and where the population are migrating back home. They look across the border. So if these dams can be set up along the migratory route, then we can save a lot, especially to reduce this conflict issue. Of course, yes, water is an issue, but a continuous process of addressing it. The other issue, the nomadic nature of our group with respect to addressing this issue. I think the best thing is to joint planning activities. Our colleagues maybe from West Pokot on the other side, Uganda, we can synchronize activity and have it jointly. Then we have a better hand on the population taken care of.
Thank you very much. In relation to the balance between clean, safe water and water for livestock, in our Trachoma region, access to clean and safe water is about 70 to 80% across the region. There are some boreholes that have been put on this story along the migratory route, and also in some of the locations that are grazing areas for the pastoralists, and also those that may migrate from either Turkana or the Pokot. At least they can have some access to clean and safe water. And also each of those water is a committee. It's a community structure that really kind of oversees the functionality of the facility and kind of tries to maybe they notify authorities in case it is dysfunctional for the period of time that these populations are there, at least there's some structure of management of the community resource that takes that responsibility. Now for the water for animals, we have some dams which are put there by the Dutch Animal Industry and Fisheries. Some of them actually don't dry. All year round they have some water. And these are areas where our pastoralists actually aggregate large numbers of both human and animal population. Those are the host areas of most of the migratory communities from Turkana, from Pokot. So they stay there for 6 months, 8 months, and there's enough water for their livestock. Now the only challenge is other complementary wash requirements or activities. I think that's where the challenge, that's where the gap is. So these are areas of high open defecation and there are potential hotspots, outbreaks like cholera and so on. There are potential spots for high transmission of cholera because of the fly populations around there. When you are approaching those grazing areas, those kraals, the thousands of flies will come you maybe like 5-7 kilometers before you. That's when you will know that I think I'm almost there. So I think those are the few things that need to really do. And then what components under the public education and integrated? We adopted the One Health strategy, and we made sure that we factored our Trachoma elimination interventions within that context. And among what we managed to integrate there was MDA. MDA helped us a lot with One Health, and it improved the coverage of treatment, and then also we could clearly demonstrate, because there are times when we did MDA, when the animal health colleagues did not have supplies. And then we compare to when we are all in the field with the animal health workers. You can see that without the animal health packages, we could perform almost about maybe 50 to 60% compared to when we went as both teams. Because we drew crowds, a lot of communities, just like what you saw from the video at Marmo, for the previous presentation. So, and then other things that can be, that were integrated actually, was TT screening. Screening for TT, and also TT cycle counts. We did all these things under One Health. For example, when we are doing MDA, we are also able to do TT screening at the same time. So the same people you are actually treating are the ones who could be having TT. And you must identify them and link them to a service delivery point. So all these things were done concurrently. And so we were able to, do too many, it was a very cost-effective approach to do too many things at once. And other things that can be integrated under One Health is surveillance. Because again, this refers to, this is closely related to the population of the crowds that you are able to pull. So you can do the surveillance accordingly. In fact, it would be advisable for us the next time we have to do a prevalence survey, which we intend to do hopefully soon. We could have an integrated approach into One Health, so that we are able to get all the examples that we need to collect from the community in the shortest possible time. Yeah, and community engagement and sensitization on the Trachoma can be integrated in one health. There are a lot of things that are closely related. Issues about wash, I've already mentioned, sanitation, hygiene, mainly, those can be easily integrated. And then the logistical needs. Take teams to the field, even reverse logistics and so on. It is possible to do all this within the One Health approach. So the supply chain in itself can as well be integrated into aspects of One Health.
Thank you, Doctor. Those are lovely insights from Uganda. So, this juncture, pass it back to the chair to introduce the next analyst.
Thank you, Titus. Thank you, the panelists. I'm not seeing Sarah from Uganda. Yeah, she's just stepped out. Huh? I wanted the Ugandan team to appreciate this team over here. The Ugandan way. Yes. Yeah, look, please. You've been volunteered by your counterpart. Huh? Show us something from the other side, Bwana. Huh?
Now, in the Ugandan way,
Yeah, the Ugandan way.
I don't know whether we copy from here. You will confirm whether we copy from here. So what we're going to do, we're going to do it very simple. We'll, you prepare your hands, people. Prepare the hands, warm them. I'm going to give the instructions. Huh? You warm the hands as I give the instructions. Here, we want someone to move outside and open their ear. Eh? We want to give the blast, the thunder. Eh? So let's go. We shall.
how the surveillance strategies, whatever we propose, will be actually able to detect signals of recrudescence in our communities. Because I think the aim and goal is to actually pick up some of these subtle signals of recrudescence, especially in the cattle corridors where even after all these years of interventions, we want to monitor them a lot closely. So in the Ugandan situation, first of all, we don't think we are going to prioritize surveillance everywhere. Not everywhere where trachoma is. But we've come up with a probable criteria of whether it is the EU's. So if you had a very high baseline TF, if you have, I'm going to introduce for another term what we are calling recrudescence and persistence of trachoma. There are areas where we've done many rounds of MDA, and after trying to run assessments, we still find trachoma has not gone below 5%, what Professor talked about yesterday. So we want to prioritize those areas. We also want to prioritize areas which have migrants and the migratory populations. We also want to prioritize or here would be sub-counties that have very poor watch indicators, usually below the national average. And the fifth criteria, we want to be able to prioritize places or districts or sub-counties that use what we call complementary indicators, where we are taking some samples from the eyes to test for the presence of the germ that causes trachoma, or where we are actually taking dried blood spots and test for antibody response to malaria. So what we are trying to do in our country, first of all, just like here in Kenya, we build capacity for testing for the presence of chlamydia in the eyes. But now even with that capacity, where do you deploy it? Because interestingly, when we are doing our assessments, it's usually a population-wide assessment. We do a bit of sampling, but now we are thinking, can we place them at health facilities and have them as our sentinel sites? But also now the question comes, how do you, if you got a few cases in the catchment, because usually these facilities, the districts or the sub-counties are usually in the catchment of these facilities. So do we equate those random cases that come and you're treating them for malaria, but you're either taking an eye swab or you're taking a red blood spot and testing either for the presence of the bacteria or the antibody response? Do you need to apply that to the general population, the results that you get from that? So those are some of the questions that we are grappling with. Trying to integrate the surveillance into, for example, malaria indicator survey, because I think about last year, this discussion was, as long as we can get a drop of blood from one of these children, then it's able to tell us something about actually, what's happening, But we also think probably if there are other assessments, especially assessments that are, involve taking of, especially samples, whether dried blood samples or what's in the community, but also how that would, especially the methodology would relate to, and how would we equate it to the prevalence of active trachoma in the population is another thing. We've also thought of integrating surveillance for trachoma with other entities. We are well aware that other entities are already, they already take blood samples, even during their routine assessments. So if we still have areas, or some of these areas, for example, a sub-county could already go into post-validation surveillance if they have achieved the WHO targets, and you still have ongoing interventions, probably for lymphatic filariasis or any other. So do we, integrate the surveillance? And so I think our discussions, we still don't have anything solid, but those are some of the things. Obviously, issues to do with the reporting and, even in the reporting, the last time we were working on the indicators at the national level, we assigned thresholds. And so we are saying, if your if your healthcare workers, for example, and are able to, they are reporting, for example, maybe, for a sub-county, 1,000 cases of bacterial conjunctivitis. Can we use that as a proxy? Because sometimes even the healthcare workers, professor here knows very much more than, I could know, but there are very many things that, fit in that definition of bacterial conjunctivitis. But again, the primary care workers will never, all of them will never be ophthalmologists. So there are those subtle things that we can pick on and see. And again, the advantage of this discussion is that there is still no gold standard. So we are all trying out. So thank you.
Thank you, Uganda. That's very comprehensive. I don't know whether Kenya, you have anything to add on that?
It's good what my counterpart from Uganda has given insights on. In Kenya, we are doing a lot of GIS. I've given an example there. We are using those innovative techniques to actually identify hotspots for targeted interventions. Another thing also I'm not seeing being done, but I've seen it in other entities, is the use of modeling and predictive AI to carry out surveillance. You don't need a whole team of survey and the cost of survey. Someone can just use thresholds like weather and migratory patterns and predict that this area is where trachoma is strike. So there are two innovative techniques that we really are employing.
Thank you very much, Kenya and Uganda. And Prof. Chair, Technical Working Group, you raised one very important thing that, yes, you are talking about integration, but we may integrate until the end of this integrating. I would want us to give, I want you to give us your views about how do you think we can integrate surveillance of trachoma to the routine health system?
I think that is a very good question, because trachoma, as we said, has got a safe strategy. And if we look at each component, we can be able to determine where it's best. And I say the easiest to fit is definitely wash, because we know there is wash for entities. I don't want to discuss beyond that, because wash is being developed for all entities, and it is an integrated approach. Wash includes BCC, behavior change communication. It's still part of wash. And that also, we have the health promotion divisions of the ministry. And we say the very simple message, like we said, don't tell the parents, because children are the one we target for facial injuries. They are the reservoir for active trachoma. Let's not pass the message, wash 3 times a day. Let's pass the message, a dirty face requires to be cleaned. The issue is to keep the face clean. Is not the number of washing. Washing is the process which makes the face clean. So our desired outcome and indicator is a clean face, not a washed face. So it's not face washing. This is not a face washing activity, it's a facial cleanliness activity. So you wash as often as it takes clean. That is one message to health promoters. The second message, which can also be included, is wash your hands, wash your face. You are told, if children are taught something like that, because even at washing, it has got a lot of support by many countries. Washing of hands before they eat, before they eat. So if you wash your hands, wash your face, wash your hands, wash your face. We can look for innovative ways of improving the wash required for trachoma in developed promotion. If you go to the issues of the A component, luckily, because we are talking about rules and regulation, this is surveillance. Surveillance means after we have been regulated. And you know, the times in some areas we have penetrated before the entire country is regulated. We need to develop even very innovative ways of doing things. Because when we do surveys, we collect data at the cluster level. If you go back to those clusters, the prevalence TT, it's not called prevalence, it's just a proportion of the number of cases with TT are not the same. And those cases can be used as indicators for the hotspots for trachoma. And those areas can be given priority attention. We must understand the epidemiology of trachoma. That trachoma is a focal disease. And we say that it's not a disease of puberty, it is a disease of poor hygiene. It is very focal. You'll find that even in a community there is a village which is retired, and it spreads from those foci, what we call trachoma nests. And it creeps the way you have got termites creeping. It is spread. So if you wipe out trachoma with MDA and you leave the nest, it is from those hotspots. That is why I'm saying, if we can identify those hotspots as sub-district level, I'm not talking of the Uganda district, I'm not talking of Kenyan County, I'm talking of a trachoma district, which is a population of 100 to 250,000. So if we identify those hotspots, we can use our community